the HMP shunt. Hey guys, this is Kevin Budashevsky, and this is G6PD deficiency. So you guys may or may not have already covered the video on the HMP shunt, but if you haven't, I would recommend seeing this prior to this video. So what is the important function of the irreversible oxidative reactions of the HMP shunt? Well, it essentially makes NADPH. The enzyme G6PD is involved in both the HMP shunt and the respiratory burst, and plays a key role in regenerating NADPH. So let's say we have a substance that's harmful to the body, like hydrogen peroxide. It can cause oxidative damage to the body if it's not dealt with, so what will our body do to protect itself? Well, the body will actually use a reduced form of glutathione to neutralize the hydrogen peroxide to water. However, to keep high supplies of reduced glutathione available, the body needs a lot of NADPH. And where did I say we got our NADPH? The HMP shunt. If we're missing the key enzyme G6PD of the HMP shunt, then we cannot make enough NADPH and our bodies can be subjected to oxidative stress without being able to appropriately deal with it. What is this? Well, this is an almost guaranteed test question. The boards absolutely love this enzyme and frequently test on G6PD, so I'd pay close attention to this video. G6PD is actually the most common human enzyme deficiency. It is X-linked recessive. One of the main problems in G6PD deficiency is that it prevents the reduction of glutathione, which makes cells much more susceptible to oxidative stress. Under normal conditions, patients with G6PD deficiency might not have symptoms, but when subjected to oxidative stress, such as things like drugs or inflammation, drugs can be sulfonamides, nitrofurantoin, primaquine, or isoniazid, it results in stress that ends up resulting in hemolytic anemia, where the red blood cells can't handle the stress and will lyse. These patients should also not eat fava beans since they contain high levels of oxidants. However, none of these are the most common cause of hemolysis in G6PD deficiency. Can you guys guess what that might be? So in other words, what's the most common cause of oxidative stress that the body experiences? That would be infection. Good. On test day, make sure you focus on the information provided. If the question depicts a black individual who is taking a new medication and develops hemolytic anemia, you should immediately think G6PD deficiency. With so many negative side effects of G6PD deficiency, are there any positives to having the disease? Well, the only silver lining is that it provides some resistance to malaria, possibly by causing higher levels of oxidative stress. How else could you be tested on G6PD deficiency? Well, one of the ways the boards likes to present this is by showing this, which is a depiction of bite cells. These are indicative of G6PD deficiency, and they're red blood cells that have bites taken out of them. So why in the heck would phagocytes bite off part of red blood cells? Well, in normal individuals, NADPH serves a protective antioxidant role to the red blood cell. If you aren't able to produce NADPH because of a G6PD deficiency, you aren't able to regenerate the reduced form of glutathione, which protects the cell from hydrogen peroxide damage. So when you can't protect the cell, you get damage to things that are inside of the cell. So in the case of red blood cells, what's mainly inside of it? Well, that would be hemoglobin. So you get denatured hemoglobin that precipitates within the cell. So this denatured hemoglobin is called a Heinz body, and these occur during times of stress. Phagocytes recognize these Heinz bodies in the red blood cells and bite off pieces of them as the Heinz body accumulates. Although knowing the contents of the Heinz bodies isn't extremely high yield for the USMLE Step 1, being able to recognize the significance of them on a peripheral blood smear is absolutely essential. So on test day, immediately think G6PD and NADPH deficiency, although other things like thalassemias and asplenic patients may also exhibit Heinz bodies for the same reason, and should be part of your differential diagnosis. Hey guys, this is Kevin Budashevsky, and this is Disorders of Fructose Metabolism. So how does fructose, a monosaccharide, fit into metabolism? Well, fructose metabolism is important because it converts a substrate for glycolysis into energy production. As you can see, fructose enters the glycolysis pathway at glyceraldehyde 3-phosphate. Normally, it's converted to fructose 1-phosphate by fructokinase in the liver. The enzyme aldolase B then converts fructose 1-phosphate to dihydroacetone phosphate and glyceraldehyde. The enzyme triose kinase can then combine glyceraldehyde and ATP to make G3P, which is one of the important substrates in glycolysis. This is in a normal, healthy patient. So what happens when you're missing key steps in this pathway? Well, essential fructosuria is an autosomal recessive defect in fructokinase. If you're missing fructokinase, what happens? Well, fructokinase is the enzyme that phosphorylates fructose after it enters the cell. And it's this phosphorylation that prevents fructose from crossing the cell membrane and leaving the cell. Therefore, without this enzyme, there's nothing keeping fructose inside of the cell. So how big of a deal would you imagine this would be? Well, there are no nasty metabolites that are building up inside of cells, and fructose can just wash out in the urine. Additionally, there are other more important sources of metabolic fuel, so not surprisingly, this is generally an asymptomatic condition. If you're a mnemonic person, you can think fructokinase is kinder. Will you see large amounts of glucose on urine dipstick in patients with essential fructosuria? No, actually, because the urine dipstick is sensitive for glucose only and not fructose. In these patients, hexokinase becomes the primary pathway converting fructose to F6B. However, fructose intolerance is a more serious autosomal recessive disorder of the enzyme aldolase B. Without aldolase B, fructose 1-phosphate accumulates, and since it's already phosphorylated, it cannot leave the cell. This consumes a lot of available phosphate. So what energy molecule is phosphate an important component of? That's right, ATP, or adenosine triphosphate. Phosphate depletion inhibits glycogenolysis and gluconeogenesis, two processes that require amounts of phosphate to operate. So without glycogenolysis, the breakdown of stored glucose, or gluconeogenesis, which is the formation of new glucose, fructose intolerance can actually cause hypoglycemia, or low blood glucose levels. You'll usually notice symptoms of fructose intolerance after the consumption of fruit, juice, or honey. So what do you think the dipstick will look like in these patients? Well, in fructose intolerance, patients will have detectable amounts of reducing sugars in the urine, but these sugars are again not glucose, so the urine will have a negative dipstick for glucose. In addition to hypoglycemia, the patients will also have jaundice, cirrhosis, and vomiting due to a toxic accumulation of fructose 1-phosphate. Again, the important part here is that this cannot leave cells, so causes damage within them. The treatment for this is to not eat fructose or sucrose, since sucrose is a disaccharide composed of fructose and glucose. In general, disorders of galactose metabolism, which we'll discuss in the galactose metabolism videos disorder video, are much more serious. Alright, time for a flash quiz. Is essential fructosuria or fructose intolerance more symptomatic, and why? Well, fructose intolerance is worse since a deficiency in aldolase B leads to a fructose 1-phosphate buildup in cells, reducing available phosphate stores. Again, this inhibits glycogenolysis and gluconeogenesis, leading to hypoglycemia.
Now next up, we have disorders of galactose metabolism. Now in galactose metabolism, galactose is converted into glucose so that it can be used in glycolysis. Now most of this takes place in the liver, but other tissues also metabolize galactose, but to a lesser extent. Now normally, dietary lactose is broken down into galactose and glucose. Next, galactose is then phosphorylated by the enzyme galactokinase to produce galactose 1-phosphate, which is converted by uridyltransferase to glucose 1-phosphate. Now glucose 1-phosphate can be converted into glucose 6-phosphate, which can be used to start glycolysis or finish gluconeogenesis, depending on the energy needs at the time. So what happens if you're missing some of the galactose metabolic enzymes? Well, galactokinase deficiency is an autosomal recessive deficiency of galactokinase. This prevents the phosphorylation of galactose and instead causes it to be converted to the alcohol form, galactitol. Now this is catalyzed by the enzyme aldose reductase, which is the same enzyme that converts glucose to sorbitol. Now, a galactokinase deficiency is usually a mild condition, but galactitol does accumulate inside cells and can cause galactosemia, infantile cataracts, and the failure to attract objects or develop a social smile. Now, how does it actually cause galactosemia if we just said that galactitol accumulates inside cells? Well, think of it as clogging up the sink. If there's nowhere for the ingested galactose to go, it will accumulate in the serum and then also be excreted in the urine. Now, classic galactosemia is a more serious autosomal recessive deficiency of galactose 1-phosphate uridyl-transferase. Now, a deficiency in galactose 1-phosphate uridyl-transferase causes galactose 1-phosphate as well as galactitol to accumulate inside of cells, causing some of the same effects as galactokinase deficiency. Now, some of the effects you can see here are infantile cataracts as well as some new signs due to galactose 1-phosphate accumulation, and these include jaundice, hepatomegaly, and sepsis in neonates, particularly with E. coli. And can you think of why neonates are particularly susceptible to sepsis secondary to E. coli and galactose 1-phosphate uridyl-transferase deficiency, or classic galactosemia? Well, the exact mechanism here is unknown, but it's felt to be due to several factors. First off, the accumulation of galactose in tissue, as well as in the blood, leads to a dysfunctional immune system. Also, the extra galactose provides a substrate for the E. coli to grow on, as E. coli here is a lactose fermenter, and remember that lactose is just galactose plus glucose. And finally, infants with classic galactosemia often have lots of GI issues when they're fed lactose or galactose-containing products, and this can result in significant vomiting, which may predispose the infants to translocation of gut bacteria, particularly E. coli. Now, these effects are similar to what you see in fructose intolerance, since in both cases you're accumulating a phosphorylated monosaccharide inside of hepatocytes, causing liver damage, and also leading to loss of phosphate stores in the process. Now, the treatment for classic galactosemia is pretty simple. You just don't eat anything that has galactose or lactose in it, which once again, lactose is just galactose plus glucose. Alright, now let's take a shot at a board-style question. A 6-month-old boy is brought to the physician because he seems smaller than the other kids his age, and he has occasional vomiting associated with bottled milk feedings. He was born at home and did not undergo any newborn screening, and on physical exam, the patient is found to have jaundice, bilateral clouding of the eye lenses, as well as hepatomegaly. The patient also shows signs of developmental delay. Which of the following enzymes is likely to be defective in this condition? Is it A, alpha-1 hydroxylase? Is it B, aldolase B? Is it C, galactose 1-phosphate uridyl-transferase? Is it D, iduronate sulfatase? Or is it E, transmembrane copper transporting ATPase? Think you know the answer? There you go. The defective enzyme here is C, galactose 1-phosphate uridyl-transferase. The question prompt here gives us all the information we need to figure this one out. Here we have a 6-month-old with vomiting after bottle feedings, as well as jaundice, lens clouding, hepatomegaly, and developmental delay. With all of that in mind, hopefully you're thinking of classic galactosemia, which is an autosomal recessive disease due to deficiency in galactose 1-phosphate uridyl-transferase. That there are essentially 2 galactose metabolic disorders that you'll need to remember for your test. The milder form, which is galactokinase deficiency, may present with infantile cataracts, but usually not developmental delays because of its benign nature. So with that in mind, you're much more inclined to think classic galactosemia if you see developmental delays. Also remember, in classic galactosemia, galactose 1-phosphate, as well as galactitol, will accumulate in organs causing damage, and this can lead to jaundice as well as hepatomegaly. Also notice that the question said that there was vomiting that primarily occurred after milk feedings. And once again, milk has lactose, which is a disaccharide that gets broken down into galactose and glucose. And what do you think the treatment would be for this kid? There you go. It's just a galactose-free diet. And real quick, just to cover the other answer choices. Answer choice A here, which would be an alpha-1 hydroxylase deficiency, can be seen in vitamin D-dependent rickets type 1. And here you'll see early onset rickets as well as hypocalcemia. Now choice B, which is due to a defect in aldolase B, is seen in hereditary fructose intolerance. And here you're going to see hypoglycemia, vomiting, jaundice, as well as cirrhosis. And it's due to an accumulation of fructose 1-phosphate, and you're going to also see decreased phosphate levels. Now answer choice B, which is due to an ironidate sulfatase defect, it's seen in Hunter syndrome. And answer choice E, which is due to a defect in transmembrane copper transporting ATPase, is seen in Wilson's disease. Well, alright, that's going to wrap up galactose metabolism. See you in the next video.
Hey guys, this is Kevin Budashevsky, and this is sorbitol. So sorbitol, which is shown here, is basically a reduced alcohol form of glucose. Sorbitol is formed by the enzyme aldose reductase. This enzyme should sound familiar, as it's also the enzyme that converts galactose to galactitol. When glucose gets converted into sorbitol, it becomes trapped inside of cells and can be later converted into fructose via sorbitol dehydrogenase. So not all cells in the body have the enzyme sorbitol dehydrogenase. Fortunately, the liver, ovaries, and seminal vesicles contain both enzymes aldose reductase and sorbitol dehydrogenase, but some lack one or both of these enzymes. As you'll see throughout clinical biochemistry, whenever a metabolite gets trapped inside of a cell, its buildup can damage host tissues. If a tissue lacks sorbitol dehydrogenase, to break down sorbitol, toxic levels of sorbitol can accumulate inside of cells, which causes damage due to sorbitol's osmotic activity. Like any other osmotically active substance, high levels of sorbitol can create a concentration gradient, pulling water into the cell, causing it to swell and potentially lyse. So in what disease would you expect this to occur at excessively high rates? Well, that would occur in conditions of high glucose, right? In states of persistent hyperglycemia, such as diabetes, high levels of sorbitol can cause damage to the lens, retina, kidneys, and Schwann cells, since these either have primarily or only aldose reductase and not sorbitol dehydrogenase. You can remember this with mnemonic lurks. This can cause cataracts, retinopathy, glomerular disease, and peripheral neuropathy, all of which are absolute hallmarks of diabetes, so this shouldn't surprise you. In contrast, the liver, ovaries, and seminal vesicles have both enzymes, so they can get rid of, or lose, sorbitol. Alright, time for a flash quiz. A poorly controlled type 2 diabetic man has poor vision and tingling in his feet. How may sorbitol be at fault? Well, this would be due to chronic hyperglycemia, or high blood sugar levels, which cause sorbitol to accumulate, which causes osmotic damage in cells. This is most prominent in cells that lack sorbitol dehydrogenase to break down sorbitol, including Schwann cells, in this case causing the peripheral neuropathy. Hey guys, this is Kevin Budashevsky, and this is lactase deficiency. So what does it mean to be lactose intolerant? Well, lactase is a brush border enzyme on the luminal side of the small intestine, shown here, which hydrolyzes or splits the disaccharide lactose into its constituents, which are glucose and galactose. These can then be brought into an enterocyte. A deficiency in this enzyme can either be primary or secondary. A primary deficiency is due to aging and losing expression of the lactase allele, usually seen in people of Asian, African, or Native American descent. Lactase deficiency can also be secondary, which is usually transient following a bout of gastroenteritis or from an autoimmune disease. Why would gastroenteritis cause lactase deficiency? Well, it can do so by damaging the luminal membrane of the intestinal brush border, which is where lactase resides. Lactase deficiency can also be congenital, but this is usually rare. How does a lactase deficiency typically present? Well, symptoms of lactase deficiency and subsequent lactose intolerance include bloating, cramps, and osmotic diarrhea. You'll see these symptoms because lactose will not be absorbed into the cell and therefore will pull water into the lumen of the GI tract due to the osmotic gradient being created. Bacteria in the gut can then use lactose to form methane, leading to flatulence. You can diagnose lactase deficiency clinically, but stool testing will demonstrate a decreased pH. Let's say you're attending orders an intestinal biopsy to determine the cause of the patient's severe diarrhea or cramps. What will the biopsy most likely show? Well, hopefully you're thinking the biopsy results will be normal. Otherwise, you're wishing your patient ill will. Rude. Remember that lactase is a brush border enzyme. If it's deficient, there will be lack of enzymatic activity on the brush border, but the GI epithelium will still look normal under a microscope. That's assuming that this is a primary defect. Of course, if the intolerance is secondary, there may well be damage in cases of gastroenteritis or autoimmune diseases. However, in the case of primary lactose intolerance, again, this biopsy will appear normal. Treatment for lactase deficiency includes avoiding lactose in the diet or taking lactase pills with food. What food products typically cause problems in those with lactase deficiency? Lactose is typically found in milk and milk products such as cheese and yogurts.
Hey everyone, let's cover amino acids. So only the L form for levo, meaning left, of amino acids are found in proteins. Amino acids can be categorized by whether they're essential or non-essential, whether they're glucogenic, ketogenic, or both, and whether they're acidic, basic, or neutral. Don't overthink this. Essential amino acids are essential, meaning you need to consume them. The consumption of essential amino acids is necessary because humans can't produce them. Essential amino acids can be remembered by this mnemonic, and that's Private Tim Haw or Pivot Tim Haw, which was the way I remembered it, so whichever way you need to make it stick. The P is for phenylalanine, the V is for valine, T is for tryptophan, second T for threonine, I for isoleucine, M for methionine, H for histidine, A is for nethine, and that's why it's lowercase in the mnemonic, L for leucine, and a second L for lysine. So the glucogenic essential amino acids, which are amino acids that can be converted to glucose via gluconeogenesis in the liver, are methionine, histidine, and valine. You can remember this by saying, I met his Valentine and she is so sweet. Sweet as in sugar or glucogenic. The essential amino acids that can either be glucogenic or ketogenic include isoleucine, phenylalanine, threonine, and tryptophan. Do you remember what the purely ketogenic amino acids are? These are amino acids that can be converted to ketone bodies and include leucine and lysine. And do you remember what enzyme deficiency requires purely ketogenic amino acids as treatment? Hopefully you remember pyruvate dehydrogenase deficiency, which requires giving these ketogenic amino acids to bypass their deficient or defective enzyme pyruvate dehydrogenase. Now, just remember that all the other amino acids that I didn't cover are the non-essential amino acids, which are the following along the bottom of the screen here. We also have acidic amino acids, which have a negative charge at physiological pH, which is usually between 7.2 and 7.6. There are only two acidic amino acids, which are aspartate and glutamate, and the alternate names for these two are aspartic acid and glutamic acid. So it's pretty easy for you to remember which two are acidic. The basic amino acids, which are usually positively charged at physiological pH, are arginine, lysine, and histidine. Arginine is the most basic, and histidine actually doesn't have a positive charge at physiological pH. Arginine and lysine are high in histones. Now, do you recall what histones are? They're the molecules that DNA wraps around. Remember that DNA is negatively charged, so the histones can increase their composition of positively charged or basic amino acids in order to attract and hold onto the DNA. The only basic amino acid that sounds like histone, which is histidine, is actually the only basic amino acid that is not really used for this purpose. And that's our video on amino acids. Thanks for watching. If you liked the video, give it a thumbs up.
Now next up, we have the urea cycle. And here we're going to talk about how amino acids are broken down. Now we've seen how amino acids are not all the same. and different amino acids go through different catabolic processes, many of which yield metabolic fuels in the form of pyruvate or acetyl-CoA to ultimately produce glucose as well as ketone bodies. Now, the degradation pathway of all amino acids produces ammonia, and ammonia, if it isn't disposed of properly, can cause some problems. So how does the body actually get rid of ammonia? Well, urea is the non-toxic disposable form of ammonia, which is synthesized in the liver and excreted via the kidneys into the urine. Now, urea accounts for about 90% of all nitrogenous compounds which are excreted in the urine. And the reactants of the urea cycle are ammonia and CO2. And this initial process requires 2 ATP. And the products of this cycle here are ADP, AMP, fumarate, as well as urea. Now, it's important to note that the urea cycle takes place in both the mitochondria as well as the cytoplasm. And you can see this here. And the rate-limiting step of the urea cycle is this first reaction, which is catalyzed by carbonyl phosphate synthetase 1. Now, once again, this enzyme converts carbon dioxide and ammonia to carbonyl phosphate. And then the carbonyl phosphate can enter the urea cycle where it combines with ornithine to create citrulline. Now, the enzyme carbonyl phosphate synthetase may sound familiar since you heard of it at the beginning of the biochemistry chapter. Just remember that carbonyl phosphate synthetase 1 is used in the urea cycle, while carbonyl phosphate synthetase 2 creates carbonyl phosphate in the pyrimidine synthesis pathway. Now, once we create a molecule of carbonyl phosphate, we're ready to take a spin in the urea cycle. Now, once again, carbonyl phosphate combines with ornithine via the enzyme ornithine transcarbamylase to create citrulline. Next, we take citrulline, as well as a sprinkle of aspartate, and some ATP to create arginosuccinate via the enzyme arginosuccinate synthetase. Now, before we keep on cycling through, let's talk briefly about the structure of urea. Now, urea itself has 2 nitrogenous groups. One of these nitrogens comes from the ammonia group that we started with, and the other nitrogen comes from aspartate, which we just added in the citric acid cycle. And the carbon that's found in urea comes from the CO2, which was originally added at the beginning of the cycle, along with ammonia. Alright, now let's just jump right back into the urea cycle. So arginosuccinate is then acted on by arginosuccinase to form arginine, as well as fumarate. And where exactly have we seen fumarate before? Hopefully you're thinking back to the TCA cycle. And here you can see how fumarate can feed into the TCA cycle so that it doesn't get wasted. Now back to the urea cycle. Next up, we have arginine plus a little bit of water is acted on by arginase to form ornithine as well as urea. Now ornithine here can be used to restart our urea cycle. And this urea molecule will travel to the kidneys where it can be excreted. Notice how it's water soluble and neutral, and we successfully rid the body of ammonia by converting it into something we can actually filter, which is urea. Now, if remembering all these intermediates and products of the urea cycle seems difficult, hopefully this mnemonic can help. And here our mnemonic is, ordinarily careless crappers are also frivolous about urination, where our O here in ordinarily stands for ornithine, where our C here in careless stands for carbonyl phosphate, where our C here in crappers stands for citrulline, where our A and R stands for aspartate, where our A and also stands for arginosuccinate, where our F in frivolous stands for fumarate, where our A in about stands for arginine, and where our U in urination stands for urea. Now last of all, it's important to note that the urea cycle requires energy, particularly about 3 ATP. 2 ATP are provided within the mitochondria to start the process, and 1 ATP is required within the cytoplasm to convert citrulline and aspartate into arginosuccinate. Alright, before we wrap up, let's take a shot at a flash quiz. The urea cycle ultimately yields blank, which can be excreted in the urine, and blank, which can enter the TCA cycle. The urea cycle is meant to excrete urea into the urine, which gets rid of nitrogen in the form of ammonia, which was formed in the body from the breakdown of amino acids. It also creates fumarate, which can be fed into the TCA cycle. Well, alright, that's going to wrap up the urea cycle. See you in the next video.
Hi guys, this is Kevin Budyshevsky, and this is transport of ammonia by alanine. Ammonia is a toxic molecule produced by muscle degradation. However, if we convert it to urea, we can safely excrete it in the urine. Unfortunately, the urea cycle only occurs in the liver. So, the problem becomes, how do we get ammonia, which is produced in muscles, into the liver? Well, this transport occurs with the help of alanine. In the muscle, the amine group that you're trying to dispose of is added to alpha-ketoglutarate in a transamination reaction, which results in glutamate. In a second transamination reaction, the amine group is transferred to pyruvate, forming alanine. So this is basically like playing hot potato with the amine group, passing it along until alanine is finally formed. And this is one of the 5 metabolism pathways that pyruvate can go down. Check out our pyruvate metabolism video if you need a refresher on this. So this is catalyzed by alanine aminotransferase, or ALT, one of the enzymes that you measure for hepatic function testing. Think L for liver, which is appropriate because ALT is actually more specific for AST for hepatic pathology, so this mnemonic holds its weight. Once alanine is formed, it can then enter the bloodstream to the liver via the Cahill cycle. When alanine gets to the liver, the transamination reactions are simply reversed. So once in the liver, the transamination reaction is reversed and the amine group is transferred from alpha-ketoglutarate to form glutamate, not shown here. The minutiae here can get really confusing, so do not get bogged down in the details. It's not worth your time. The big picture is that we have toxic ammonia that builds up in muscles. A transamination reaction allows us to bring this group back to the liver via alanine in the Cahill cycle. Once in the liver, this transamination reaction is reversed, termed deamination, so that the ammonia, that again was brought here via the help of alanine, can be excreted via the urea cycle. See our urea cycle video for more details.
Hey guys, my name's Christina, and this video is on hyperammonemia. Imagine you're on your family medicine rotation. You are chart checking a patient who just checked in, looking at the chief complaint, recent visits, lab work, and medication list. You notice a patient is on lactulose, and you quickly recall from your pharmacology lecture that this is used to decrease ammonia levels. How exactly does this medication work? And what would happen if the patient stopped taking this medication? You're going to learn all about hyperammonemia. After the next few slides, you should be able to 1. Understand how ammonia levels become elevated, 2. Describe the clinical signs and symptoms of hyperammonemia, and 3. Describe the various treatment options. Alright, so what is ammonia? Ammonia is a nitrogenous compound composed of nitrogen and hydrogen. Ammonia itself is toxic to our body, especially to our brain, and needs to be converted to urea, a non-toxic substance that can be excreted renally from our body. Ammonia is synthesized by amino acid metabolism and converted into urea through the urea cycle. While we won't go over the urea cycle in detail, I do think it's important to understand this picture here. Ammonia is synthesized by amino acids through muscle breakdown. It is then converted to glutamate, which is then converted to alanine, and alanine serves as a shuttle and can be transported from the muscles to the liver, where it can then be converted back to glutamate. This glutamate can now be used in the urea cycle, and will eventually form urea. Urea can now be excreted renally through our urine. This concept was always a little tricky for me to understand, but I think truly understanding the alanine and glutamate relationship within the muscle and liver helps. For more detailed information, check out our great video on the urea and alanine cycles. Okay, so how do ammonia levels become elevated? Well, as we just went over, the liver is a site where ammonia is broken down and put through the urea cycle to form urea. So any dysfunction in this cycle would cause hyperammonemia. This is typically seen in very advanced liver disease or hereditary urea cycle enzyme deficiencies. Excess levels of ammonia will be converted to alpha-ketoglutarate to form glutamate. This depletes the supply of alpha-ketoglutarate. When alpha-ketoglutarate supply is depleted, which important metabolic cycle is inhibited? Hopefully, you think of the TCA cycle. High levels of alpha-ketoglutarate also depletes glutamate and GABA stores in the central nervous system, which contribute to the encephalopathy symptoms patients may have. Elevated ammonia levels can cause flapping tremors, also known as asterexis, slurring of speech, somnolence, vomiting, cerebral edema, and blurring of vision. Can you recall the most common urea cycle disorder? Yes, ornithine transcarbamylase deficiency. The enzyme ornithine transcarbamylase catalyzes an essential reaction early on in the urea cycle. If this enzyme is deficient, our body cannot produce urea, and a buildup of ammonia occurs. This usually presents in the newborn stage of life with symptoms of hyperammonemia, including poor feeding, seizures, somnolence, abnormal movements, and encephalopathy. Lab findings also reveal elevated orotic acid in blood and urine. A deficiency in any other enzyme used in the urea cycle can also lead to hyperammonemia, though ornithine transcarbamylase deficiency is the most high yield. Organic acidemias, such as propionic acidemia and methylmalonic acidemia, can also cause high ammonia levels. Check out our videos on organic acidemias for more information. So how do you treat hyperammonemia? The mainstay in treatment is to limit protein in the diet, but there are a few different ways you can lower ammonia levels within the body. Recall lactulose, the drug we were introduced to in the beginning of this video. Lactulose works to lower ammonia levels by acidifying the GI tract. When you give lactulose, the ammonia gets converted to ammonium, which cannot cross the gut epithelium and will then be released through bowel movements. Other options include giving antibiotics, such as rifaximin or neomycin. These work to kill bacteria in the gut that produce ammonia. The USMLE exam is a critical thinking exam, so in the spirit of critical thinking, would you guess that rifaximin is a well-absorbed or poorly absorbed antibiotic? As you can imagine, a well-absorbed antibiotic would enter the bloodstream and peripheral tissues rather quickly. And do we want this? No, we want the antibiotic to stay in the gut where it can kill ammonia-producing bacteria. Therefore, rifaximin is poorly absorbed. This is why you probably haven't heard, or you're probably not familiar with it being used for anything else. Amino acid binders, such as benzoate or phenylbutyrate, can react with glycine or glutamate to increase excretion of ammonia. Okay, let's do a quick flash quiz. What are some signs and symptoms of hyperammonemia? Elevated ammonia levels can cause asterexis, slurred speech, somnolence, vomiting, cerebral edema, and blurring of vision. These are very important to recognize and highly tested on exams. Alright, so the bottom line, ammonia is a toxic substance synthesized by amino acids through muscle breakdown. Liver disease, urea cycloenzyme deficiencies, and organic acidemias are prime causes of hyperammonemia. And lastly, there are many different pharmaceutical agents available to lower levels of ammonia, including lactulose, rifaximin or neomycin, and amino acid binders, benzoate or phenylbutyrate. Thanks for watching. If you enjoyed this video, don't forget to give a thumbs up.